Thank you, Mr. Chairman. Ladies and gentlemen, good morning. First, I'd like to thank the organizing committee for giving me permission to present this paper. It's on modified reverse noose with pre-sternal compression for repair of pectus carinatum. I'm from Brunei. This is my hospital, Ripas, Raja Istri Penggana Anak Saleha Hospital. It's the main tertiary referral hospital with about 900 beds. That's Professor Park, if you recognize him. He came over. Kindly came over in 2001 to help us set up our pectus repair program. The case I'm going to present and perhaps get comments from the floor on how to improve is on a 10-year-old Malay boy with midline symmetrical pectus carinatum. Up to now, we've all been doing mainly excavatum, and we rarely see carinatum, but this is the first case of the lower third sternum. Past medical history of had pyloric stenosis repair as a baby. He's otherwise healthy, no non-allergies, short for stature, and probably slightly more frequent bouts of upper respiratory tract infection. This is his CT scan. You can see the much of the deformity, the pectus carinatum, is at the bottom part of the sternum. And the Heller index we calculated is about 1.99. Currently, has already presented by the two earlier speakers. The technique that's currently being used are the Abramson technique, which is a subcutaneous pre-sternal compression, and also where the bar stays on the outside and you have to anchor it onto the ribs to provide the compressive pressure. And of course, you also heard from Professor Park, which uses the sandwich technique for compressing the deformity together and remodeling the chest wall. If you look at the noose technique, in actual fact, it works very well because it works on the force and counterforce principle, where the bar sits under the sternum, providing an outward force, but the component of bar outside provides an inward force to counteract and this is how it provides the outward force. And the reverse noose uses the same force and counterforce principle. Preoperative preparation, we use cefuroxime, single lumen. I rarely use double lumen because most of these are children. We don't have double lumen tube for children. We elevate the chest with sandbag. The arms are lifted above the head because the anesthetist can access all the lines with no tension or stretch. This is the preoperative image. You can see the pectus there. We mark the position where the bar will go. Pre-measured bar, about 11 inches, bilateral, single lateral incision. I do use a 5mm camera port at the fourth intercostal space for all my tunneling. This is to help me visualize and avoid any cardiac or mediastinal injury. The bar is pre-bent to desired result. Here we enter the sixth intercostal, pre-mark, sixth intercostal space, and then exit again at the fifth intercostal space to lie just above the sternal plateau, and likewise on the other side as well. The bar is pre-bent. I may have done a bit more angulation but later on we'll come to that. This is just a cartoon to show you. I didn't take any operative images of what we actually did. So the bar goes in at 6, exit the 5th, and stays outside and provide the compression. Of course, anchoring is done usual way for excavatum. I use a hinge plate at the entry point and also anchored down. I use Ethibond. This was the technique shown to me by Professor Park, and we anchor further down here as well. This is what it looks like. Postoperatively, as you can see, we may have overdone the compression, so creating a minor degree of excavatum. I had to go back on the same sitting and pre-bend, took the bar out. It was quite difficult once you put in to pull the bar out because with the rib on either side, it was actually keeping the bar in. So you had to apply a lot of force just to pull it out. But we pre-bent the bar and inserted, and the result was slightly better. So, and then concluded the procedure. Extubated on table. Analgesia, I use PC8 for 24 to 40 hours and then change to oral paracetamol and tramadol. I usually put radivacdrain subcutaneously for 24 hours and then remove it. patients are usually discharged by 5 days. No post-operative complication. There was no brachial plexus or neurological injury. Follow-up, I usually follow up for about 1 week, 3 weeks, 6 weeks, and then 3 months. But unfortunately, this patient, initially, the patient did very well. Just prior to 3 months appointment, the mother brought the child in early because the right end of the bar has actually protruded out through the skin slightly. And I knew by then that the bar has dislocated. You can see here, it's dislocated. Took the bar out. This is the repair. This is the child at 2 weeks post-removal. The wound has healed. Actually, the child was quite happy. The mom was quite happy with initially the plexus was there, but now the abdomen is fairly straight now. I had to look at, if you look at the literature and on pectus carinatum repair, the incidence of, this is I think a review paper on several, all the articles that's been written on carinatum. They noted that there's an 18.18% displacement. And recently we had heard from regarding pectus carinatum, and that was in terms of displacement, overall complication 1.1, of which some of these were displacement. So the incidence of displacement for carinatum repair is actually much higher than that of excavatum. And if you look at the force that's applied, the bar is actually pushing outward and inward on the side, but the sternum is actually pushing inward. So actually, for excavatum repair, the sternum is actually pushing inward, trying to keep in a way, trying to keep the bar in. But if you look at carinatum, it's actually pushing outward. So that if this force is greater, there's a net force trying to push the bar out. So what's the solution? Well, if you think about it, the respiratory movement, we breathe about 12 to 16 breaths a minute. So in 5 months, there's about over 2 million movements. If you look at, and I thought about it, the way the rib works probably is similar to this gun here, which is a silicon gun. Every time you pull the gun, it moves it forward. So every respiratory movement that the child makes moves the bar laterally slightly. So solution would probably is to anchor at 3 points, perhaps using wire. I don't normally use wire because they tend to fracture, but in this case, we might have to anchor strongly at 3 points. Or alternative solution that we recently heard about is not just anchor wire, but also perhaps the flare buster and the magic string mic for anchorage on the outside may be a solution as well. Thank you.